biologically important bases are twofold, the bicarbonate as well as the biphosphate. So what is acid-base homeostasis? It is usually defined by the concentration of hydrogen ions. And to achieve homeostasis, there must be a balance between intake or production as well as the net removal of hydrogen ions from the body. So in a very simple language, when we say acid-base balance, it is largely about the balance between these two very important ions, hydrogen ions and bicarbonate ions. So what is pH then? pH refers to potential hydrogen. Acidic or basic nature of any solution is measured by hydrogen ion concentration. But as we all know that the concentration of hydrogen ion in biological fluids is exceedingly low, therefore the conventional units are not used to measure pH. And that is why we usually represent pH as negative logarithmic concentration of hydrogen ions. So if you can see, if we look at the value, it will be very cumbersome to repeatedly talk about 0.000004 in routine languages. That is why we use the concept of pH to explain these things in a very simple fashion. And as you can see that pH 7 is something which is neutral, neither acidic or basic. When we go down, it is increasingly acidic. So a pH of 1 is 0.1. On the contrary, if you go upwards, you will find it as increasingly basic, and this is how we represent it. So low pH values indicate high hydrogen ion concentrations. So this is something, there are three different images, 1, 2, and 3. So pure water is neutral. Why we call pure water as neutral? Because if you look at this, number 1, the concentration ion and hydroxyl ions, they are equal. That is why the pH is neutral. On the contrary, in this image number 2, you would see that the hydroxyl ions are more. So this is a base. On the contrary, here you will find that the hydrogen ions are more. So this is a solution. Basic content. The reason for that is that small changes in pH can produce significant major disturbances. For example, pH changes have dramatic effects on cell function. It can change the excitability of nerve and muscle cell. It can influence enzymatic activity, and it has specific influences on potassium levels. As you are aware from your understanding of CNS, that when the pH is decreased, or in other words, when it is an acidotic environment, it depresses the CNS, and that can lead to unconsciousness. Similarly, an basic or alkalotic environment, when the pH is higher, it can cause overexcitability. And as you saw in the last seminar, we talked about that. There will be tingling sensations, nervousness, and muscle twitches. Similarly, most enzymes, they function only within very specific narrow pH ranges. When pH increases, or can alter the shape of the enzyme. And when the shape is rendered, it is changed, you would see that the substrate won't be able to attach to the enzyme molecule, which will affect the various biochemical reactions. What are the influences on potassium levels? So if hydrogen concentration are high, or when the environment is acidotic, then hydrogen would be secreted in greater amounts, as lectures and renal physiology. So what will happen because of that is that this will leave less potassium than usual to be excreted. So less potassium is excreted, that means that there is potassium retention. When there is hyperkalemia or potassium retention, it can affect cardiac functions. And as you know from your knowledge of cardiovascular system, that in ECG, tall T waves are seen during hyperkalemia, isn't it? So our body constantly produces generally more acids than bases because acids are taken in with foods. They are normally produced by metabolism of lipids and proteins. And cellular metabolism also constantly produces carbon dioxide. So the basic reaction which goes on within the body is CO2 combines with water to form carbonic acid, which dissociates between hydrogen ions and bicarbonate. So now goes the very important question. If so many changes are happening within the body, how the body defends against fluctuations in pH? So this balance is maintained by three different systems. Number one, this is buffering system. Number two, through lungs, and number three, through kidneys. So inadvertently, the first line of defense, immediate changes in the pH will be detected by chemical buffer system. And these are accordingly, we can call them as bicarbonate buffer system, phosphate buffer system, and protein buffer system. The second and third line of defense against shift in pH will be physiological barriers, in which you will see that respiratory mechanisms will come into play. For example, carbon dioxide retention or excretion. And then even if the system fails, we move on to the more solid system, but which will take some time to function, and that is renal mechanisms, which is hydrogen ions excretion or retention. So let's take them one by one. The first one is your buffer system. As I said, it is the first line of defense. It reacts instantaneously, and that's why immediate changes in pH are detected by buffers within our body. And as you know, a buffer is a combination of chemicals in solution that resists any significant change in pH. So they are able to bind or release free hydrogen. So what are the various types of buffer systems? So the most important buffer system is bicarbonate buffer. It is active in both ECF and ICF. Then in ICF fluid, we have phosphate buffer, which are normally active. Then we have protein buffers, which are the largest buffer store. And the examples include albumins and globulins, as well as hemoglobin. Hemoglobin are in ICF, whereas albumins and globulins, they are in the ECF. So this is the important reaction, bicarbonate to carbonic acid. As we know, this is the body's major buffer. Carbonic acid is H2CO3, bicarbonate is bicarbonate. Their normal ratio is 1:20, and their individual ionic concentrations are 1.2 milliequivalent and 24 milliequivalent per liter. This normally happens at pH 7.4. So the second system after chemical buffer is physiological buffer. In that, the first one is respiratory regulation. So the mechanism of control how the respiratory system or lungs maintain pH is twofold. Number one, the lungs can hyperventilate. When lungs are hyperventilating, you are taking oxygen in. And what you are doing, you are blowing off CO2. The second is hypoventilation, in which what will happen is that you will tend to retain more of carbon dioxide. So by using these two mechanisms, the respiratory system tries to control pH regulation. This regulation is also rapid. It takes seconds to minutes. And normally we measure it by the concentration of partial pressure of CO2, which is normally 35 to 45 millimeter mercury. So how does it act? What is the respiratory control of pH? So what happens is that cells, they constantly produce carbon dioxide. So their concentration increases within the cell. They bind with water to form carbonic acid, which dissociates to release hydrogen ions. Release of hydrogen ion will lead to acidosis. The pH will drop. And as you know that hydrogen stimulates respiratory center in medulla oblongata. So what will happen because of that? The rate as well as depth of breathing will increase. And that will lead to elimination of carbon dioxide from the lungs, and the pH will try to restore towards normalcy. So this is how this will function. The third physiological buffer is your renal regulation. It is pretty slow because it takes hours to days, but this is the most effective mechanism. And the reason that if kidney fails, pH balance fails. And that is why kidneys are very important for our survival. And what is the mechanism of control? Perhaps in the renal physiology lecture, you must have read about the acidification of urine. So there are largely three mechanisms within kidney. The first one is reabsorption of filtered bicarbonate. Second is generation of new bicarbonate, and third is excretion of hydrogen ions. So this probably must have been covered already. But this is how the kidneys regulate the pH. So this diagram summarizes the three mechanisms: the chemical buffer within circulation through buffers, then the physiological buffers happening at the level of lungs and the kidneys. So let's move on to the main topic of the session today, which is acid-base imbalances. So when we have accumulation of acids, that leads to increased concentration of hydrogen ions. This can also happen when there is loss of bases. Both of these conditions together will lead to drop in the pH, or in other words, there will be an acidosis. So you can see that the curve will shift to the left side during acidosis. On the contrary, when there is accumulation of bases or loss of acids, there will be decreased concentration of hydrogen ions. So the pH will increase, and the pH will increase, it will shift towards the right side, and we will call it as an alkalosis. So in acid-base imbalances, the ratio 20 of 1 goes out of balance. The condition is acidosis or acidemia. pH falls below 7.35. There is increase in blood carbonic acid or decrease in bicarbonate ions. The reverse happens in alkalosis when the pH is greater than 7.45 and there is increase in bicarbonate. Now, we can classify the acid-base imbalances based on what is their primary cause or what is their origin. Accordingly, we can classify acidosis or alkalosis into two different types. These are metabolic or respiratory. So we have metabolic acidosis, metabolic alkalosis, we have respiratory acidosis, we have respiratory alkalosis. So how to differentiate between these? We need to see what is the primary cause. So if there are changes which are happening at the systemic alterations or at the level of the cellular level, we will call that imbalance as metabolic imbalance. If the changes are brought about by respiratory alterations, we will call it as respiratory. In addition, there are a few more things which are more important when we'll go to the clinics, but it is important to know the basic physiological basis of that. So the first one is compensation. Compensation is when there is a corrective response of kidneys and lungs. Accordingly, we can have a compensated response or we can have an uncompensated response. The compensated response is when there is a restoration of pH and 20:1 ratio. Uncompensated, as the name indicates, when there is an inability to adjust that ratio. So therefore, we can classify the acid-base imbalances into four types: respiratory acidosis, alkalosis, metabolic acidosis, alkalosis. To understand these, you need to know these three very important values. So the normal value of pH is 7.4. The normal value of bicarbonate is 24 milliequivalent per liter. And the average PCO2 concentration is 40 millimeter mercury. If you remember these three, then you are able to comment or diagnose the acid-base imbalances. Let's take the first example. Respiratory acidosis. So this is basically caused by hypercapnia due to hypoventilation. So there is hypercapnia due to hypoventilation. It is characterized by a decrease in pH and increase in CO2. So you can see that in the capillary there is an increased concentration of CO2 over here, which will lead to decreased pH. So the metabolic balance before the onset of acidosis, it was normal. The pH was 7.4. What happens when there is respiratory acidosis? You can see in this diagram, the balance shifts. It becomes from 1:20 to 2:20. The pH decreases. It becomes 7.1. The breathing is suppressed because of holding of carbon dioxide in the body. So once there is respiratory acidosis, what will be the body's compensatory response? The body's compensatory response would be that kidneys will try to conserve bicarbonate ions to restore the normal 40:2 ratio. So what kidneys will do, they will try to eliminate hydrogen ions in the form of acidic urine. In addition to that, if there is an uncompensated response, what is the management or what is the therapy required to restore the metabolic balance? So lactate solution is used in therapy because the bicarbonates ions are converted in the liver by this mechanisms. So we basically provide lactate solution. This was respiratory acidosis. Let's move on to respiratory alkalosis. In this, the cause is hyperventilation. So when there is hyperventilation, it leads to eliminating excessive amounts of carbon dioxide. So increased loss of CO2 from the lungs at a rate faster than it is produced takes place, which led to decrease in hydrogen ion concentrations. So what happens in respiratory alkalosis? The normal 1:20 balance again shifts towards the right side. The pH is 7.7. There is hyperactive breathing, which tries to quote unquote blows off CO2. What would be the response of the body? The kidneys will try to conserve hydrogen ions and eliminate bicarbonate ions in the form of alkaline urine. What is the therapy or management in this particular case? We will provide chloride solutions so that the bicarbonate ions are replaced by chloride ions. Let's move on to the third one, metabolic acidosis. Now this is important because please pay attention to the graph. Metabolic acidosis is always characterized by a reduction in plasma bicarbonate. This blue one is the plasma bicarbonate. You can see it is dipping down. On the contrary, if you can see, the CO2 concentration remains normal or unchanged. So please remember that when we are talking about metabolic acidosis, it is usually the reduction in plasma bicarbonate, whereas CO2 remains normal. So in metabolic acidosis, the acidosis results from excessive loss of bicarbonate, which flows from the body, or from an accumulation of acids. So accumulation of non-carbonic plasma acids uses bicarbonate as a buffer for the additional hydrogen ions, thereby reducing bicarbonate levels. So again, the pH shifts to around 7.1. The bicarbonate decreases because of excessive presence of ketones, chloride, or organic ions. The hyperactive breathing takes place as a response, or in other words, the homeostatic response towards compensation, which tries to blow off the CO2. The kidneys try to conserve bicarbonate by producing or eliminating hydrogen ions in acidic urine. The treatment in this case would be lactate containing solutions, so that the bicarbonate gets converted in the gets converted to bicarbonate in the liver. The fourth one is metabolic alkalosis. So as we know that the gastric juice contains large amount of hydrogen chloride, and as you know from your learnings from the HCl secretion, that during the HCl secretion, the bicarbonate ions are actually added to the plasma. So this is your stomach, this is your capillary. What happens? Chloride goes inside the stomach, bicarbonate comes into the capillaries, right? There is formation of hydrogen chloride. So what happened later on is that this bicarbonate is neutralized as HCl is reabsorbed by the plasma from the digestive tract. And this is how it happens. It dissociates between hydrogen ions and chloride concentrations. Hydrogen binds with the bicarbonate in the plasma to form carbonic acid. And you can see that this neutralizes the bicarbonate ions. Now, what happens during vomiting? When a person is vomiting, what happens is that hydrogen ions is lost as HCl, right? And the bicarbonate, which is there in the plasma, is unable to get neutralized, right? So loss of HCl, as it normally happens during vomiting in the plasma bicarbonate, results in an increase in the pH of the blood. So that during vomiting, the HCl goes outside. This bicarbonate will not be neutralized. The body is that there will be metabolic alkalosis. So normally the pH is 7.4. In alkalosis, it becomes 7.7, right? The body's compensatory response will be twofold. Breathing will be suppressed to hold CO2, and the kidneys will try to conserve hydrogen ions to eliminate bicarbonate ions in alkaline urine. The management of therapy would be that we will try to replace hydrogen bicarbonate ions with chloride ions. Therefore, we will provide chloride containing solutions. So let's summarize acidosis. Acidosis can happen because of three things: by accumulation of CO2 in blood, accumulation of acid in blood, and by excessive loss of sodium bicarbonate from the blood. Accumulation of CO2 in blood, it might happen because of decreased removal of CO2 from the lungs. This will cause respiratory acidosis. When kidneys fail to excrete acids, when there is metabolic acid being produced, there is production of keto acids, there is absorption of metabolic acids from the GIT. What it will do is that it will produce more acid in the blood. Similarly, prolonged diarrhea, excessive loss of sodium bicarbonate from the blood, deep vomiting from GIT. I'm saying deep vomiting, and that what will happen is that the alkaline content from the intestine will go outside, in contrast to the HCl alone. Kidney diseases like uremia, all of these will lead to metabolic acidosis. So either it is respiratory or metabolic. Both of these acidosis will lead to depression of the nervous system. Similarly, causes for alkalosis could be hyperventilation, loss of acid, accumulation of base. Hysteria, anxiety, it is very commonly seen in hyperventilation, overdose of certain drugs, or when you go to high altitudes. All of these might lead to respiratory alkalosis. The causes for loss of acid is prolonged vomiting. And the causes of accumulation of base will be ingestion of alkaline drugs, excess aldosterone, and metabolic alkalosis, right? So this prolonged vomiting will lead to alkalosis, loss of acid, right? And either it is respiratory or metabolic, it will lead to alkalosis, which can cause overexcitability of nervous systems. There are numerous examples in the clinical states which led to derangement in acid-base conditions. For example, in case of respiratory alkalosis, you will find certain conditions like pulmonary embolus, cirrhosis, and pregnancy causing that. On the contrary, vomiting and diuretic use might lead to metabolic alkalosis. COPD leads to respiratory acidosis. Shock, severe diarrhea, renal failure may lead to metabolic acidosis. In addition, to make things more complicated, septicemia, sepsis may lead to a mixed picture where you will find both respiratory alkalosis or metabolic acidosis. So now comes the important question. Okay, so what is the clinical evaluation? How will you diagnose which condition is what? So there is a three-step algorithm which I'll talk about right now. In addition to that, for postgraduates, there is a graphical analysis which we call as acid-base nomogram, which are used, or Davenport diagram, or Sigard-Anderson curves. But the most important thing to diagnose, which you should know and which will be very handy for you guys when you move on to the second professional, is that there is a 3-step algorithm or a 3-step approach. The first thing is you need to estimate the pH. Once you know the pH, you can comment whether it is acidic or alkalotic environment. Once you know the pH, the second thing would be, please identify the primary disturbance. To which value CO2 or bicarbonate is outside the normal range and could be the cause of the problem. So if the cause is a change in PCO2, you would say that the problem is respiratory. If the cause is bicarbonate, the problem is metabolic. Third would be, which is more important when you go to the internship or takes a post-graduation, analyze the compensatory response. Look at the value that doesn't correspond to the observed pH change. Then you can compensate whether there's an acute compensation or there is a uncompensation taking place. So there is an acid-base nomogram, which is again a chart where we plot the logarithmic values. This will give you an idea about the various conditions, various disorders. So it is beyond the purview of the undergraduate education, so it is more important for the postgraduates. Similarly, we have a Sigurd-Andersen curves. But for you guys, it is very important that you remember these 3 values in identifying the acid-base imbalances and diagnosing the acid-base imbalances. What are these 3 values? Normal pH 7.4, PCO2 40 mmHg, bicarbonate 24 milliequivalent per liter. This flowchart is from Guyton. It will show you a 3-step approach algorithm. So the first step is, for example, if a patient comes in medicine, emergency, the first thing will be we will take the arterial blood sample. We will do ABG analysis. So they will give you the value of pH. So once you have the value of pH, you will see whether it is less than 7.4 or more than 7.4. Accordingly, you will diagnose either acidosis or alkalosis. You can comment on the primary cause of origin if you know the values of bicarbonate and PCO2. So that would be your second step. Try to identify the primary cause of origin. Accordingly, you can categorize acidosis either as metabolic or respiratory. The third thing would be, based on that, try to see what is the normal compensation under these derangements. For example, what would be the respiratory compensation in metabolic acidosis? The PCO2 will be less than 40. Or similarly, in case of respiratory acidosis, the bicarbonate will be more than 24. So this is a 3-step algorithm. Identify the pH, step number 1. Diagnose acidosis or alkalosis. Identify the primary cause of origin. Is it metabolic or respiratory? Third, identify whether compensation has been occurring or not. So let's give you a very, very common example, which will help you in understanding these things. Let's take one common example that you are in emergency, you have got these values, right? So the pH is 7.58. The PaCO2 is 23. The bicarbonate is 21, right? Now the first question will be, look at the pH. Is it acidosis or alkalosis? You may type your responses in the question tab. So absolutely correct, Gaurav Tiwari. It is alkalosis because pH is 7.58, right? So that is the first step. What is the second step? Look at bicarbonate. Is it metabolic alkalosis? You may respond in the question tab. So there are, there are varied responses for question 2. Look at the bicarbonate. So bicarbonate here is 21. The normal range is 22 to 30. So we're not saying that this is metabolic alkalosis. Why? So let's understand that why we are saying that. The third step I told you is that because we need to see whether compensation is happening or not. So what is the PaCO2? The PaCO2 here is 23. Is it respiratory alkalosis? Okay, so most of the people are saying yes. It is indeed a respiratory alkalosis. Why? Because the PaCO2 is normally 35 to 45. In this case, it is 23, quite reduced, right? So the fourth one is more important. See if appropriate compensation has occurred. So the compensation for respiratory alkalosis is increased bicarbonate excretion, as I told you, right? So the normal bicarbonate range was 22 to 2030. And here what you are seeing is that it has come down to 21. And there was a reason why we are not calling it as metabolic alkalosis, because this is actually an acute response to respiratory alkalosis, that the body is trying to compensate. They are trying to excrete bicarbonate, and that is why you can see that the value is being decreased from normal 22. It is coming down to 21. It will further go down as the body continue its responses. So let's move on to the next question, which is, we described her acid-base condition. So it is actually, I've already told you, acute respiratory alkalosis. And what are the plausible causes for this? We covered the possible causes for this condition in the third physiology seminar. So can you identify what are the possible causes for acute respiratory alkalosis? If you refresh your memory of pathophysiology of tetany, does that ring a bell? One of the most common cause of acute respiratory alkalosis is hysterical hyperventilation. So this lady who reported into, say, GTB emergency, and she was in a dizzy state. And what are the possible cause of her dizziness? Her possible cause of dizziness could be, as you know, because of acute respiratory alkalosis, a decrease in PaCO2 will lead to cerebral vasoconstriction. When there is a cerebral vasoconstriction, there is a decreased blood supply to the brain, and this will lead to dizziness when there is a hysteria, right? So how will it manifest? It can manifest through carpopedal spasm, which was covered by Pragya in the last seminar. So as you already know that when there is increase in pH, there will be increased calcium binding to albumin, which will decrease free calcium. So there will be more negative threshold for muscle cell depolarization, which will lead to hypocalcemic tetany, right? Let's take one more example. pH is 7.29. So it is pretty simple to diagnose. This is acidosis. So question number 2 is more important. Look at the bicarbonate. Is it metabolic acidosis? So thank you, Sumit, for responding to that. That anxiety might be a cause in the previous condition. That's correct. And Bhavya and Farid also for saying hyperventilation as the causes. What about the bicarbonate in this condition? It is given as 12. So the bicarbonate is 12. The normal range is 22 to 30. So it would be metabolic acidosis in this condition. Right. So thank you for responding, Manish, Anish, and Bhavya. Look at partial pressure of CO2. Is it respiratory acidosis? It is 26. Conflicting responses. Himanshu says no. Madhur says yes. Liaquat says no. Kriti says yes. Vishal says no. So that is the beauty of, acid-base disorders, and that is why the life and emergency is very exciting. When you get these cases, you have to immediately respond to these conditions, right? So the partial pressure of CO2 here is 26. The range was 35 to 45. It is not respiratory acidosis. And why? Perhaps because the compensation for metabolic acidosis is hyperventilation, right? So you can see the PaCO2 is 26. So we can say that partial compensation has been happening in this condition, Yeah, you're correct, Pragya. So case 3 is we have again 3 conditions. pH is tricky, 7.05. Acidosis, it was pretty simple. Look at bicarbonate. So we are getting the responses. So it is metabolic acidosis indeed. Look at PCO2. Is it respiratory acidosis? It's 45 mmHg. Possibly, we might say that because compensation will give us more idea. Because in case of metabolic acidosis, excuse me, the compensatory mechanism is hyperventilation. And in this case, the PaCO2 is 45. Normal range is 35 to 45. So it is reaching towards the upper borderline. So we might say that there is a respiratory acidosis. Right. Let's move on to the last one. 7.44 is the pH. What would you say? Is it acidosis or alkalosis? So it is pretty close, you can say, but still slightly on, you may say, on the alkalotic side of the normal. Look at the bicarbonate. So Gaurav says metabolic alkalosis, Shivam says alkalosis, Shubham says metabolic alkalosis, Gaurav, Bhavya, Madhur says yes. Sonu says metabolic alkalosis, Shivam says metabolic. So yeah, great to see your responses. So you are able to understand a very complex topic. So it is certainly metabolic alkalosis. And is it respiratory alkalosis? It is not, because you can see that the PaCO2 is 65. So appropriate compensation for this particular condition would be, see, the compensation for metabolic alkalosis would be hypoventilation. So when there is hypoventilation, there is increased PaCO2 concentration, right? But PCO2 here, you can see it is 65. It is too high for compensation. Therefore, you might say it is respiratory acidosis. And that is why it is certainly not uncommon that many a times in emergencies, you might see various patients which are presenting with a mixed picture. For example, there might be a mixed metabolic alkalosis and respiratory acidosis. And it could be because of various causes. In this particular case, the causes for metabolic alkalosis, excuse me, the cause for metabolic alkalosis might be a diuretic axis. And for respiratory acidosis, it may be COPD with hyperventilation. It may be CO2 insensitivity. You might have heard the name blue bloaters. It might be because of that. So there might be different reasons for that. And that is why it is very exciting, the emergency field of emergency medicine. But it is very important that you need to know the underlying mechanisms and that is why this 3-step algorithm, which is given in your Guyton, and I'm sure it will be given in your other books as well. And if you remember the 3 values of pH, PaCO2, and bicarbonate, you will be able to grossly identify the 4 acid-base imbalances. The first, identify the pH. Second, identify its primary cause of origin. And then try to see if you know your pathophysiological mechanisms very well or your homeostatic mechanism very well, try to see if there is an underlying compensation or not, right? And accordingly, you can plan your management or your treatment part. So, well, don't get scared. I mean, usually we get no responses, but I'm very happy today that we have got so many responses today in our comment box or our chat box. So I would suggest you that since now you have got a hang of it, try to refresh or revise these concepts once again from your text